Hello everyone, welcome back to my channel Microbiology Simplified. I hope you are all doing fine. I am Dr. Amit Kumar Singh, your guide and mentor. And this video PYQ series, I will be discussing about lab diagnosis of syphilis. This topic itself is very important both for UG students and for PG aspirants, because you must have seen several questions from this topic in PG examination. And this video will contain all the necessary information which will help you to answer the question asked in the examination. So just go through this video, make your own notes and revise it frequently. So let's start with the video. So as usual, let's start with the MCQ. A 40-year-old male truck driver came with complaints of painless, indurated genital ulcer. He had a history of unsafe intercourse 2 months back. Which of the following can be used to diagnose the condition in a low resource setting when an active ulcer is present? So what they have asked, they asked the diagnosis of an active ulcer in a low resource setting. So what is this ulcer? This ulcer, on the basis of information given, if you see, it is a painless indurated genital ulcer. So if you remember the DD of painless indurated genital ulcer, as I have told you in this STI genital ulcer video, this is a case of syphilis, as there is a history of unsafe sexual intercourse 2 months back. Okay, on the basis of this, duration of incubation. Okay, so this is a case of syphilis. You can go through the video if you have any doubt. Okay, so what could be the method of choice for diagnosis? So and they have asked especially for a low resource setting. So obviously if it is not mentioned low resource setting, then the answer should be this fluorescent treponemal antibody absorption test. Okay, but as they have mentioned low resource settings, so obviously this fluorescent treponemal antibody absorption test cannot be performed in a low resource setting, so this is out. This treponemal pallidum immobilization test, though it is very specific, but there is a disadvantage that it is very hazardous, so obviously it cannot be performed in low resource setting, so this is also out. So VDRL needs a light microscope, so this can be performed in low resource setting. Dark field microscopy also needs a dark field microscopy, that can also be performed in low resource setting. So then what should be the answer, dark field or VDRL? So as they have asked, specifically mentioning that an active ulcer is present. So if an active ulcer is present, remember, if an active ulcer is present, so the best method for diagnosis is direct demonstration of the organism. Okay, in any case, in any bacteria, anything, if the lesion is present and if you can demonstrate or isolate the organism from the lesion, then that is the best method for diagnosis. So in this case also, as the active ulcer is present, so the best method is dark field microscopy, which will directly demonstrate the organism. VDRL will not demonstrate the organism. VDRL will only indicate the presence of antibody, and it may be, in this case, the antibody may not have yet developed, because it may be a case in which the active ulcer is present occurred recently. So that's why the investigation of choice in this case in a low resource setting will be dark field microscopy. So to understand this better, let's see the algorithm. So algorithm for testing a case of syphilis, if chancre or the lesion is present, so we will go for dark field microscopy or direct fluorescent antibody test for treponemal pallidum. Okay, or if it is not present, then we can go for this non-treponemal screening test, as we can do VDRL or RPR. Okay, and if dark field or direct fluorescent antibody test is positive, it will confirm the infection, which can further confirmed by serological test. But if it is negative, what we can do, we can perform this non-treponemal screening test. If that too is negative, then repeat the test after 1 to 12 weeks. Okay, and even after that, if it is negative, then it is not a case of syphilis. Now, if this non-treponemal screening test is positive, so can we confirm the diagnosis? No, because it is non-treponemal, that is non-specific or treponemal test. So we need to confirm it with specific treponemal test. So perform the confirmatory treponemal test. If that confirmatory test is positive, then it is consistent with infection. If that confirmatory test is negative, so can we tell that it is not a case of syphilis? No. Then we have to perform adjunct confirmatory test apart from the primary or the main confirmatory test. We should perform an adjunct confirmatory test which can confirm the diagnosis. Okay, and what is that adjunct confirmatory test which we use to perform commonly is Western blot. Okay, so this is the algorithm for testing syphilis. Okay, So the lab diagnosis of syphilis is basically divided into two parts. First is serological test and second is direct detection. Serological test can be performed in all the stages of syphilis. However, direct detection cannot be performed in all the stages. It is usually performed in the primary and secondary stage of syphilis in which active lesion is present. Okay, so it is performed only in primary and secondary stage when active lesion is present. Then only we can demonstrate the organism. Na? That's why it is performed only during primary and secondary stage when active lesion is present. Primary syphilis active lesion, chancre. Secondary syphilis active lesion, rash, mucocutaneous lesion like condylomata lata, mucus patches. So we can directly demonstrate the organism in these lesions. So what are those methods? First, I told you in the question itself, dark field microscopy. Second is direct fluorescent antibody for Treponema pallidum. Third is nucleic acid amplification test, and fourth is silver staining. Serological test is further into two types. One is specific for treponemal, that is known as treponemal test, and one is non-specific for treponemal, that is called non-treponemal test. The treponemal test includes FTA-ABS, TPHA, MHATP or TPPA, EIA or CLIA, immunoblot assay or multiplex flow immunoassay. And non-treponemal tests include VDRL, RPR, USRT and TRUST. Okay, so these are the various tests which can be performed for diagnosing case of syphilis. Okay, so we'll go one by one. Okay, so direct detection we will start with. So direct detection, dark field microscopy. So when to perform dark field microscopy? Obviously when the primary and secondary lesions are present. Okay, and it can also be performed in immunodeficient person and in case of early syphilis when the antibodies are not yet detectable. Okay, and how to perform? So the best suitable lesion to perform dark field microscopy are moist lesions. Okay, if the lesion is moist, the chances of recovery is very high. Okay, so moist lesion is the most suitable lesion for performing dark field microscopy, and it should be examined within 20 minutes of collection of the specimen. Otherwise the organism may dried up and will not be able to find the organism in the lesion. Okay, and how we will identify the organism on the basis of characteristic morphology, how it will look like, thin coiled structure, and also by motility. And what is the limitation of dark field microscopy? Antibiotic treatment, if it is given, then it may lead to false negative results. So that is one limitation. Second, negative result does not exclude diagnosis. So even if the dark field microscopy is saying negative, so we will not exclude the diagnosis. We have to confirm the negative result with further serological test, as I have told you in the algorithm. And it is not suitable for oral and rectal lesion. Why? Because in oral or rectal mucosa, non-pathogenic treponemes may be present, and this dark field microscopy cannot differentiate pathogenic and non-pathogenic treponemes. Okay, so that's why it is not suitable for oral and rectal lesions. Remember this. Okay, so you can see in this image this thin coiled structure in dark field microscopy prepared from a lesion. Okay, so dark field microscopy is clear. Now we'll come to direct fluorescent antibody for Treponema pallidum, DFA TP in short. And when to perform? Obviously when the lesions are present. And how it is performed? For this we will use fluorescent tagged monoclonal or polyclonal antibody, and that fluorescence used is fluorescein isothiocyanate, FITC labeled monoclonal antibody. Okay, and this monoclonal antibody suspension will help to detect the Treponema pallidum antigen in the smear prepared from the lesion. Okay, and it can perform directly in the specimen. Okay, and advantage, it is not dependent on motility. So if Treponema pallidum antigen is present in the smear, so this fluorescent tagged antibody will bind to it and will give fluorescence. So it will not depend upon the motility, okay, of the organism to detect the organism. Okay, second, it can be used for oral and rectal lesion because it is able to differentiate between pathogenic and non-pathogenic treponemes. So it can be useful for oral and rectal lesion. Why it is able to differentiate between pathogenic and non-pathogenic? Because it is using a specific antibody to Treponema pallidum. So that's why it is able to distinguish between pathogenic and non-pathogenic treponemes. But then what is the limitation? It will not be able to distinguish between the subspecies of pallidum, though it may correctly identify that it is Treponema pallidum species, but which subspecies? Because as I told you in the stages of syphilis video, that there are 3 more subspecies of Treponema pallidum apart from subspecies pallidum, which causes yaws, endemic syphilis and pinta. So those subspecies will not be able to distinguish on the basis of this DFA-TP. So this is the limitation of that. Okay. So you can see in this image this fluorescence produced by binding of this fluorescent tag antibody with the Treponema pallidum antigen in the smear. Okay. Now the third is nucleic acid amplification test, and this is actually because as we know that Treponema pallidum cannot be grown in routine culture, so it is a useful tool for direct detection of the organism in the smear. And how to perform this? Can be done by PCR, by nested PCR, by quantitative PCR, and by reverse transcriptase PCR. And to perform this, we will use certain gene. And what are those genes? Treponema pallidum lipoprotein gene, that is TPP47, which is most commonly used, and then DNA polymerase gene, Pol A gene. And what is the advantage? It has got very high sensitivity and its specificity is around 100%. Okay, so this is the advantage of nucleic acid amplification test. Okay, and now coming to the last method of direct detection, that is silver staining. And when to perform the silver staining? Obviously, when the primary and secondary lesions are present. And the silver staining method have 2 types. One is Fontana's method, which is used for staining films. Okay, so you can remember it like F for film, F for Fontana. And the second method which is used for staining tissue section is Leva-Ditti's method. Okay, so Leva-Ditti's method is used for tissue section. And advantage, it is more sensitive than direct fluorescent microscopy. Okay, so this is an advantage of silver staining over DFM. And how? Because it eliminates interference of mucous filament and fibers present in the exudate or the lesion. So that is why it is more sensitive. So you can see in this image, this darker stained thin coiled structure are Treponema pallidum. Okay. Now coming to the non-treponemal test. Non-treponemal test includes VDRL, RPR, USRT and TRUST. And what it will detect, this non-treponemal test, it will detect total antibodies against a lipoidal antigen. What is the total antibodies? Total antibodies means IgG and IgM. Okay. And what is this lipoidal antigen? This lipoidal antigen basically composed of cardiolipin, lecithin and cholesterol. So this is the main antigen, and these 2 are added to stabilize the antigen. Okay, so cardiolipin, lecithin and cholesterol. Okay, and the antibody which is detected against this antigen is known as reagin antibody. Okay, so this reagin you can see in this name, rapid plasma reagin, unheated serum reagin test. Okay, so this reagin is basically antibody. This reagin, don't confuse this reagin with the IgE antibody. This is not IgG, this IgE, this is IgG or IgM. Okay, okay, this is not IgE. And these antibodies are non-specific antibodies. That is why it is called as non-treponemal test. Why it is non-specific? Because these antibodies may be produced against, because the antigen cardiolipin, this cardiolipin antigen is not specific to Treponema pallidum. It may be also present in mammalian tissue. That's why this antibody is non-specific. So VDRL is 100% sensitive in secondary stage of syphilis. And during primary stage of syphilis, it is around 70 to 80% sensitive. Okay, and it is performed, the principle behind is microflocculation test. Microflocculation test. Okay, microflocculation test is a type of precipitation test. Okay, remember, it is a type of precipitation reaction. Okay, and it will detect reagin antibody. So the specimen of the serum which we do, in which we perform the VDRL, should be preheated at 56 degrees Celsius for 30 minutes. And why we should do this? To inactivate the complement, which may lead to non-specific antigen antibody complex formation. Okay, and this is not required if you are examining the CSF specimen. So it is only required when we are examining serum. So preheating is required only for serum, not for CSF. Okay. And the advantage of VDRL is that it is only acceptable non-treponema test for CSF. Okay. So non-treponema test performed for diagnosing a case of neurosyphilis is VDRL, known as CSF VDRL. Remember this. And the modification which we can see in VDRL is USRT. What is that? USRT, unheated serum reagent test. Unheated serum reagent test. So we will not heat the serum this time. So first of all, the antigen which is used in VDRL should be stabilized. So this is stabilized by adding EDTA. And what EDTA will do? EDTA will eliminate the need for daily preparation of antigen. In VDRL, we cannot store the antigen once it is prepared. So it has to be prepared daily. But in case of USRT, it need not be prepared daily because it is supplied by adding EDTA. Okay. And choline chloride is added to eliminate the need for preheating. Okay. So we don't preheat. So that's why it is known as, the test is known as unheated serum reagent test. Both the tests are performed microscopically. Remember this. Both these tests are performed microscopically. So this VDRL is performed in a concave slide, and this concave slide, you see there are 12 concavity in this slide, and this is actually this purpose of this 12 concavity slide is to dilute the serum to know the titer of the antibody present in the serum. Okay, and this is the microscopic image of this microflocculation reaction in the slide. So the needle shaped cardiolipin crystal will form clumped with each other, and it indicates a reactive reaction. Okay, so this is a reactive reaction of VDRL. So now the next non-treponemal test is rapid plasma reagent test, and it is also 100% sensitive in secondary syphilis, and this is a macroflocculation test. So that was a microflocculation test which requires microscope, and this is a macroflocculation test, so it will not require microscope. So why? Because this cardiolipin antigen is added with a charcoal particle. So this charcoal particle which is added with cardiolipin antigen will act as a visualizing agent, which will help to visualize the result by naked eyes. Okay, so we can visualize the result in RPR by naked eyes. Okay, and also preheating is not required in case of RPR, as similar to USRT. And there is a modification of RPR which is known as TRUST, which is toluidine red unheated serum test, in which instead of charcoal particle as a visualizing agent, we will use toluidine red as visualizing agent. Okay, and it has got better specificity compared to RPR. Okay, so it is more specific compared to RPR. Okay, so you can see in this image this black color charcoal particles form clumps. So this is a positive reaction, and it does not form any clumps, so this is a negative reaction. So it is a macroflocculation test. It is again a type of precipitation reaction. Okay, remember this. So the non-treponemal test advantage, it is used to monitor disease activity, and a 4-fold or greater decrease in titer indicates successful treatment. So the titer of non-treponemal antibodies decreases after treatment. So a 4-fold or greater decrease indicates successful treatment. And if a 4-fold or greater increase in titer occurs, then what it indicates? It indicates reinfection or relapse. Okay. And biologically false positive reactions also occur, as it is non-specific antibody. So it is due to cross reactivity, and it may be because of some infectious diseases such as chickenpox, hepatitis, infectious mononucleosis, measles, mumps, leprosy, bacterial enteritis, brucellosis, or it may be due to some non-infectious diseases such as connective tissue disorder, autoimmune diseases, ulcerative colitis, vasculitis, malignancy, and intravenous drug use. And also there may be cases of false negative because of prozone phenomenon. I will make a separate video for prozone phenomenon. Prozone phenomenon occur because of antibody excess. Okay, antibody excess. So this can be eliminated by serial dilution of specimen. Okay, So false negative result may occur by antibody excess, and this is known as prozone phenomenon. Now coming to the treponemal test. The treponemal test, the first one is fluorescent treponemal antibody absorption test, FTA-ABS. And when to perform this fluorescent treponemal antibody absorption test? It can be performed in all stages of syphilis. It has got very good sensitivity and specificity in all the stages of syphilis. Okay. And how it is performed? So first of all, the specimen, the serum samples will be pre-treated with Reiter's treponemal. And what is that Reiter's treponemal? Reiter's treponemal is basically non-pathogenic treponemal known as treponemal phage Dennis. Okay, treponemal phage Dennis. So we will treat the specimen first with Reiter's treponemal, and this pre-treatment is known as absorption. What it will do? It will remove all the group specific antibodies. Okay, so once the group specific antibody is removed, we will add to the slide fixed with Nichols stain. So we will prepare a slide in which already a Nichols stain. What is that Nichols stain? Nichols stain is the pathogenic treponema, that is Treponema pallidum, which is maintained by serial passaging in rabbit testis. So we will prepare a slide which is fixed with Nichols stain, and then we will add the serum which is already absorbed with the Reiter treponemal to remove the group specific antibody. So it will only, if it contains, it will only contain the antibody is specific to Treponema pallidum. So if it is present, it will bind with the Nichols stain in the slide. Okay, so this is the Nichols stain in the slide, and if the serum contains the antibody against Treponema pallidum, it will bind to it. And after that, we will cover the smear with fluorescent tagged anti-human immunoglobulin, which will bind with this antibody. Okay, so it will give fluorescence. So if the patient serum contains the antibody against the Treponema pallidum, it will bind with the Nichols stain which is fixed on the slide, and then it will bind with the fluorescent tagged anti-human antibody. Okay, and we can visualize the antigen antibody complex via fluorescence. Okay, so you can see in this image, this fluorescence is because of binding of the fluorescent tagged antibody, anti-human antibody with the antigen antibody complex formed in the slide. Okay, so this is FTA-ABS. So the absorption, the importance of absorption is to remove group specific antibody, and which strain is used for that? Reiter's strain. And what is Reiter's strain? Treponema phage Dennis, which is a non-pathogenic strain, and that can be cultured also. Okay, remember this. Now the second treponemal test, MHA-TP or TPHA or TPPA. When it is to be performed, it also can be performed on all the stages. And how? It is an agglutination assay, and this agglutination assay can be microheme agglutination or Treponema pallidum heme agglutination assay, or it can be Treponema pallidum particle agglutination assay. So what is the difference between these three? These two, heme agglutination assay is basically agglutination assay performed by using sheep RBC. Okay, and this is performed by using particle, and these particles are gelatin particles. So what is the difference between these two? This Treponema pallidum heme agglutination assay is performed in test tube, and this microheme agglutination assay is performed in micro titer well. Micro titer well. Okay, so this is performed in micro titer well. Okay, so it will utilize sheep RBC, which is sensitized with Treponema pallidum, and this will use sensitized gelatin particles. So instead of sheep RBC, the gelatin particle is used, which is coated with the Treponema pallidum antigen. Okay, and then it will add it to the patient serum. So if the patient serum contains the antibody specific to the Treponema pallidum, so it will bind with it, and lead to a reactive result. So how the reactive result will look like? It will lead to formation of a smooth mat on the base of the well in the microtiter well, okay, or in the base of the test tube in case of TPHA. Okay, so this smooth mat formation on the base of the well or the tube indicates a reactive reaction. Okay, and this TPPA has a better sensitivity compared to MHA-TP or TPHA. Okay, this has got better sensitivity compared to MHA-TP and TPHA. So this is nowadays used more commonly, TPPA. Okay, so you can see in this image, this buttonhole formation in the bottom or the base of the well indicates negative reaction, and this smooth mat formation, okay, you cannot see any buttonhole like this, so this indicate a positive reaction. So smooth mat formation positive, buttonhole formation negative, remember this. Okay, so now see the next toponymal test, EIA and CLIA. Advantage of EIA and CLIA is the sensitivity and specificity. It is comparable to TPH and FTABS, and though it is very simple to perform and it can detect separately IgM and IgG. Okay, and it is used to diagnose congenital syphilis because of this reason, because it can separately identify IgM and IgG. Okay, immunoblot assay, it is an adjunct confirmatory test, as I told you in the discussion of the algorithm. It is an adjunct confirmatory test which is performed if the primary confirmatory test is negative. Okay, and this is highly specific and can separately detect IgM and IgG similar to EIA and CLIA. And the sensitivity and specificity is almost 100%. So that is why it is used as an adjunct confirmatory test. Okay, and how it is performed? It detects antibody against recombinant antigen. And what are those recombinant antigen? TP and 15, TP and 17, TP and 47. Okay, so you can see in this image the bands are formed in this TP 47, 17 and 15. Okay, so this is immunoblot assay. Now this multiplex immunoflow assay, it is an automated flow cytometric assay. It is based on fluorescent bead technology. It is based on fluorescent bead technology, and it is similar to EIA except that the capture antibody is attached to bead instead of the well. Okay, and the advantage, it is able to detect and differentiate treponemal and non-treponemal antibodies. Okay, so this is an advantage of multiplex flow immunoassay. And it also detects antibody against recombinant antigen. What are those antigens? Similar to that used in immunoblot assay, TP and 15 and 17 and TP and 47. Now anti-treponemal IgM. This anti-treponemal IgM is specific to treponema. Okay, and it is indicator of recent infection in adults and in neonates. So it indicates recent infection in adults and neonates both, and it declines at around 4 months after treatment in adult. Okay, and it is used mainly for diagnosis of congenital syphilis. So what are the method which is used for diagnosis of congenital syphilis? FTA, ABS, IgM, immunoblot IgM assay and EIA IgM assay. So these are three methods which can be used for separately detecting IgM antibody. FTA, ABS, IgM, immunoblot IgM and EIA IgM. Okay, so as I told you, this treponemal IgM, this is specific, and if you see this treponemal IgM will start declining after around 8 weeks and will disappear after around 2 years of infection, and later on it is replaced by treponemal IgG. So that is why this treponemal specific test cannot be used for monitoring the therapy, because the antibody will remain positive even after the treatment response. However, this non-treponemal IgM, IgG, if the patient is treated, it will fall, it will decrease. So the antibody, non-treponemal IgM antibody can be used for monitoring the therapy. Okay. Now evaluation of neurosyphilis. Neurosyphilis can be evaluated by CSF examination and by serological test. CSF examination which can be performed to evaluate neurosyphilis are mononuclear pleocytosis, in which the WBC should be more than 5 per microliter of CSF, increased protein more than 45 gram per deciliter. But this may be confounded by HIV co-infection in patients suffering from syphilis. So for that, the cutoff for the CSF cell count is made 20%. So if a person is suffering from HIV, and also suffered from syphilis. So diagnosis of neurosyphilis should be done on the basis that the CSF cell count should be more than 20 rather than more than 5 in case of non-HIV infected individuals. Okay, so this is CSF examination. Serological test can be performed by CSF VDRL reactivity, and it is highly specific and it is diagnostic if it is reactive. So if CSF VDRL is reactive, it is diagnostic of neurosyphilis. Okay, but the sensitivity is less. In FTA, ABS is more reactive compared to CSF VDRL in all the stages, and if a non-reactive result occur in case of FTA ABS, it will rule out asymptomatic neurosyphilis in late disease, but not in early disease because of absence of antibodies. Okay, so these are the tests which can be performed for evaluating a case of neurosyphilis. I know this video is very long, but if you'll go through this video, you will definitely be able to answer all the questions from the lab diagnosis of syphilis. So just go through this video, make your own notes. Don't worry. All the best. Take care. Bye-bye.